Please welcome my next guest, Dr. Lindsey Buckingham from Novant Health Cancer Institute. Welcome, Lindsey.
Thank you.
It's so good to have you here. Thank you for coming today. I know it takes time out of your busy day, but we're really happy to have you here. So I always start with my new guests with your background. Tell me a little bit about where you grew up, where you went to school, and your training.
Sure. I'm a native North Carolinian.
Wow.
Yeah.
One of few.
Yeah. I grew up outside of Chapel Hill in a town called Pittsboro. And did essentially all of my education at UNC, so undergrad and medical school, and then for residency was in Philadelphia for 5 years, which was really great, and then was lucky enough to come back home to UNC for my fellowship training, which has led me up to here.
Wow. Oh, that's great. There aren't that many locals. Sometimes everybody's from somewhere else.
Yeah, yeah.
Yeah, that's great. Tell me about your residency and your fellowship.
Yeah, so when you practice GYN oncology, you actually start as an OBGYN. So for 4 years, I trained in Philadelphia doing general women's care. So I delivered babies, did gynecology, did a little bit of oncology at the time. But really developed an interest in practicing surgery and taking care of cancer patients. And so applied for and matched for a fellowship in oncology here at UNC in North Carolina.
Wow. So you're qualified to do a lot of things, really.
Yeah. I could still deliver babies if I needed to.
If you had to, yeah. If we had a hurricane and we all got shut down, you would have to probably deliver babies. Now, I know you focus on gynecological cancers. So can you give me an overview of what's the most common gynecological cancer?
In the United States, it's endometrial cancer. It's the 4th most common cancer in women.
Really?
Yeah.
Wow. Are there symptoms for that? Do you know that ahead of time?
Unlike ovarian cancer, yes.
Yeah.
Oftentimes, women with endometrial cancer will present with bleeding, vaginal bleeding after menopause. Most women, thankfully, will get into their doctors pretty quickly, and that will tip us off that there's something to be done. And we often find these very early.
Oh, that's great.
Yeah.
Are there certain risk factors that lead to that endometrial cancer?
Yeah, we know that as obesity has been increasing, especially in the United States, endometrial cancer has been increasing along with it. Anything that can increase your levels of estrogen in the bloodstream would put you at risk for endometrial cancer. Obesity is our big one in the United States, but also never having children is another risk factor.
I know a little bit about the HPV vaccine. Can you talk to us about that and who can get it, the vaccine, and why should they get it?
Well, everyone should get it. And it's really important because both men and women can carry HPV. Most frequently, women have symptomatic or asymptomatic, but cellular changes from the infection. And so it's important because it's sexually transmitted that we actually start vaccinating our kids well before they're sexually active. So these days, I'm pretty sure the American Academy of Pediatrics would recommend, I think by age 9, we start vaccinating for HPV. But for women, previously it was up to age 26. It's a 3-vaccine panel that you complete, and that's going to help prevent the HPV infection, which can lead to cervical cancer. We can now use that vaccine in women up to age, I want to say 45.
Really?
Yeah, and even if you've already got an HPV infection, it's been shown to help reduce the risk of subsequent cervical cancers.
And so when you give them at age 9, that's for boys and girls alike?
Yep.
And what kind of cancer, or does it increase the risk of cancer in boys? What kind of cancer would?
Yeah, penile cancers for men, and then head and neck cancers.
Head and neck. That's interesting. I know that some of the cancers that you've spoken of are caught early, but some unfortunately are caught later. And so can you talk a little bit about the different types of treatments, the treatment options for both early detection and late detection?
Sure. Early's usually fairly easy. So particularly in endometrial cancer, when we can find cancer early, we get to do surgery. And for a lot of women, surgery is all that's needed.
And you remove the uterus?
Correct. Yeah, so a surgery for endometrial cancer involves removing the uterus with the cervix, the fallopian tubes and ovaries.
Oh.
And then in general, we're looking at lymph nodes in the pelvis, sampling those on each side of the uterus. For a large majority of women, surgery is enough. Sometimes a little bit of radiation after surgery is necessary, but usually this is a short course, and it's to kind of make sure that the cancer stays away once you've taken it out surgically. And with ovarian cancer, which is the one that we tend to detect later, unfortunately, we kind of have two options up front. And so with the diagnosis of ovary cancer, you'll sit with your gynecologic oncologist and talk about, should we do surgery first or should we do chemotherapy first? Survival is actually the same.
Is it?
Mm-hmm. We do know that. But what matters is when you do surgery, you're able to get everything out.
Yeah.
And so if at presentation it doesn't look like that's possible, we do chemotherapy first. We usually do 3 cycles. We do a scan and assess to see if we can do surgery yet. If we can't, we can do more chemo. Otherwise, we go to surgery to remove all the same organs as endometrial cancer, and in addition, the omentum and anything we can see in the belly that looks cancerous. Ovary cancer really is managed by chemotherapy, and oftentimes multiple lines of chemotherapy are required during a person's lifetime. But I think the positive is that women are living longer and longer with ovary cancer, even though the stage at presentation really hasn't changed much over the years.
With the endometrial cancer, once you remove all of that, will women have to continue treatment? Do you have to do anything afterwards? Do you take by mouth or chemo or?
For endometrial,
it depends on...
it a little bit depends. So for endometrial, oftentimes we're able to just treat with some radiation after the fact. If you have some of the more uncommon but more aggressive cell types, we may treat with chemotherapy. It's usually 6 cycles. Gynecologic oncologists do 6 cycles at a time and kind of assess from there. Ovary, though, before or after surgery, you'll have chemo, and then we just kind of assess for response, and oftentimes women are on chemo for quite a long time for ovary.
Do you work in connection with their other doctors with primary care, and how is that all handled?
Yeah. GYN onc is very multidisciplinary, so we're really close with our radiation oncologists, and in fact, we have frequent meetings called a tumor board where we discuss our patients, and rad onc's there, radiology's there, pathology is there. When I do surgery, I often go to the pathologist's suite and look at my slides with them to see exactly what they're seeing in my patient. And so we have close relationships with the other doctors. I also think from a primary care standpoint, it's important that their doctors kind of know what's going on. And so at least at initial consult, we make sure to reach back out and communicate what's going on. And then if there's any needs otherwise, we work together during treatment to make sure that our patients are plugged in.
Yeah. Well, it's been very enlightening having you on the show. You're my first gynecological oncologist. It's hard to say.
Yeah,
even.
it's a mouthful.
Yeah, it is a mouthful. But thank you so much for coming today. I wish you a very happy New Year.
Thank you.
And I hope you'll come back and see us.
Sure.
Yeah, we can talk about your research opportunities.
Yeah, that would be lovely.
Okay, great. Thank you so much.
Thank you.